The today topic of discussion is regarding an important, very clinically useful drug which is dapagliflozin. This topic will be covered under the following headings as shown. First, we will see what is this drug. This comes under the category of SGLT2 inhibitors. The drug is available by the various brand names. What is this drug? This is a category of SGLT2 inhibitor drugs. What is this SGLT2? It is sodium glucose co-transporter channel inhibitors. This is present specifically in the kidney, nephron, and the proximal tubule. These are all the channels with which sodium and glucose being absorbed together into the body. So this is it regarding what is this drug. This is a group of drugs comes under the category of SGLT2 inhibitors. There are many other gliflozin drugs are available. For example, empagliflozin, dapagliflozin, and under these dapagliflozin is a one drug under this category. Going to mechanism. So in the slide you are seeing the structure of a nephron. So there is the glomeruli, this entire structures are the tubules. In the proximal tubule where the reabsorption occurs, the glucose, sodium, the other electrolytes being filtered from the blood vessel into the glomeruli, and this side inside the tubules we can say the urinary area. That is for a better understanding. From the proximal tubule, where is the proximal tubule? In this area, from the proximal tubule, proximal converter tubule, there are many channels. One among them is the sodium glucose co-transporter, if lumen, or we can say it's the urinary side. If sodium and glucose are there, both will be absorbed through a particular channel, and that is being blocked by this drug. So what will happen once this is blocked? The sodium and the glucose will be excreted into the urine. So this is the basic mechanism. The SGLT1 channel is also there, but 90% absorption of the glucose in the kidney occurs through SGLT2. And this drug dapagliflozin is having specificity for this particular channel. So this is all regarding the mechanism of the drug in gross. I'm not going into the detail of further how it is nephroprotective, how is cardioprotective, not into those details. Just it is blocking the drug so that the excretion of sodium and glucose is increasing. So coming to the dosage, what is the commonly used dosage is the 5 milligram or the 10 milligram one. Most of the times we might start the drug with 5 milligram and the dose can be escalated to 10 milligram. This is the common dosage formulation which is available. And what are all the uses? Initially, the drug being introduced into the market in the treatment of diabetes. Diabetes, hyperglycemia, blood sugar levels are high. You block this channel, sugar will be excreted into the urine. So that is where it is being used. Basically, this drug, the chemical formulation being derived from a apple tricha bark, where there was a particular chemical which blocks this channel. From there, historically, they have worked on it. Finally, this drug being approved through various research and also in 2014 they approved this drug for diabetes. But apart from that, through various other research work, they have found this have many other roles. It is having cardiac protection or the congestive cardiac failure. Even the mortality benefit or the morbidity benefit is there in the cardiac condition. It reduces the progression of chronic kidney disease through various mechanisms. The mechanism involving tubuloglomerular feedback decreases the fibrosis. The mechanism discussion itself is a separate topic, but as of today, you can remember it is being used in the stopping the progression of the chronic kidney disease. Mortality and morbidity benefit is there. And it is, apart from that, it is having many other pleomorphic roles in the form of reducing the oxidative stress, reducing the inflammation, and also it causes weight loss, stabilizing the uric acid level, reduces the uric acid level. So these are all the, and also it has some vascular benefit by reducing the overall oxidative and the inflammatory stress. Overall vascular function is better. So these are all the common usage in the diabetes, in the CCF, in the CKD. It is having the benefits and other pleiotropic effect this drug is having. For the particular pleiotropic drug we won't use clinically, we are using this for 3 conditions. And in OPD, what is the problem we encounter is whenever we write this drug for a CKD patient, they usually ask, sir, this drug is given in Google as being used in a diabetic patient. And why I'm not a diabetic, why that drug is being given? So it is because considering the chronic kidney disease, probably we have given the drug. So these are all the important use of this drug. Coming to the side effect, what are the side effects this drug can cause? Side effect, or we can say certain complication we have to look out for is UTI, since the sugar content in the urine is increasing as it is blocking the sodium glucose co-transport, the glucose content in the urine is increasing. So there is a risk of UTI. Genital infection, even it is very common in the female patient, especially who are diabetic. Genital infection is very common, and also in male, one particular point to mention with respect to MCQ also is the Fournier's gangrene. The perineal gangrene can occur, very rare, but genital vaginitis, vulvovaginitis, these kind of infections are common. Third one is the euglycemic ketoacidosis. The sugar might be on the lower level, but patient might go into diabetic ketoacidosis. This is also very common. Always have to look out for when the patient presents with acidosis. There is a history of intake of these SGLT2 inhibitors. Even though sugar is less, always send a urine ketone level and try to manage in lines of diabetic ketoacidosis. The other things are volume depletion, dehydration, because the sodium is getting lost, the water is getting lost, there is an osmotic diuretic effect. These are the things that might get lost in the urine. So there's a chance patient might develop this kind of volume depletion in terms of dehydration. This can happen. And creatinine can rise. The patient might encounter sometimes AKI also, because there is a volume depletion. If the patient didn't take adequate water, there's a chance the patient will develop AKI. If the rise is more than 30% creatinine, you have to stop the drug. So that detail we will see in the last slide. So with respect to the side effect, 3 things you have to look for is the infection, euglycemic ketoacidosis, and the volume depletion can occur. Always look out for. So that's why in high risk patient we start at the low dose and titrate the dose further. Regarding few other clinical data, so what is the EGFR? As a nephrologist, we always get the references for stopping the drug or continuing the drug. What is the EGFR cutoff? Previously it was 30, now various research or evidence-based medicine, as per the research latest trials, up to EGFR 20 we are giving. Few cardiologists stop the drug if it is going below, the EGFR start going below 30. But as a nephrologist, since this is having nephroprotective uh, one of the mechanisms reducing the fibrosis and thereby nephroprotection. So till 20 we are using this drug and recommended also. Few textbook mention it as 25, few as 30, but as for the latest update it is 20. And if the patient EGFR falling below 20, considering the cardiac and other pleiotropic benefit, this drug can be continued at the lower dose. The second one is, when was the FDA approval came? In 2014 they approved it for diabetes. In 2022 they approved it for other pleiotropic benefits, especially the cardiac component and the renal component. 2022 they have approved. Other clinical question that we always encounter is when to stop the drug, especially when there is a more than 30% rise in the creatinine after starting the drug within the first week or the first 10 days. The drug have to be stopped. And one more point, if the patient developed recurrent UTI, if the patient developed one-time UTI, we won't stop it. If the patient is developing recurrent UTI, what is recurrent UTI? For MCQ point of view, it is 3 times in a year. If the patient is developing recurrent UTI, that is 3 times in a year, you have to stop the drug. Even if a patient developed life-threatening euglycemic ketoacidosis, better not to consider, because it is the balance between risk and benefit. If the risk is more, better to stop the drug. And one more point regarding the T of is, after taking the drug, the T of is around, we can say, 12 to 15 hours, and it will be excreted mainly through the urine, around 70 to 90% being excreted by the urine, very less through the GI tract. And when to avoid, whenever considering this is drug, the whether to add the drug or not to give the drug, that won't go by the particular value of the creatinine or the particular risk factor. You have to take the patient into a overall condition. What is the risk of dehydration? What is the risk of ketoacidosis? What is the risk of UTI? All three have to taken into consideration. If you think any of the risk is high, better to avoid this drug. The nephroprotection you can give through some other drugs in the form of RAS inhibitors. Better to avoid this drug, because the UTI, better to avoid this drug because the UTI might have a greater impact rather than reducing the progression of the CKD. As an example, a patient who is having digestant and had past history of renal stone disease, better to avoid this drug, because if a UTI occurs in a patient who is having a foreign body which is degestant, the effect of UTI will be devastating. So in this condition, better to avoid this, because dapagliflozin increases the risk of UTI. So this is one clinical info with respect to the references we usually or commonly encounter. And I hope I covered all the clinical points related to dapagliflozin, when to stop and all, and how long to continue, when to monitor after 1 or 2 weeks. Especially first week after starting the drug, you have to repeat the KFT and look for the signs of rise in the creatinine. And after that, every third month probably you have to do it. And again, all depends on the various other clinical parameters of the patient. It is not a 2 plus 2 equal to 4. It won't work that way. Many other parameters have to be taken into consideration and you have to decide. So this is all regarding the drug dapagliflozin. In the next video, in the drug series, we will see regarding some other drug. Bye bye. Thank you.